Oh,
You're
sorry,
muted.
sorry. Okay, here we go. Good morning, everyone. Welcome to TeleShadowing. We are live on YouTube now. Please feel free to ask any questions in the chat box as we go along, and they'll be addressed. My name is Amna, and I'm a rising M1 at the University of Maryland School of Medicine. I'm honored to introduce our mentor and guest speaker, Dr. Melanie Swift. Dr. Swift is an accomplished internist and occupational medicine specialist whose passion for improving the health and well-being of healthcare professionals has made her a national leader in her field. Dr. Swift currently serves at the Mayo Clinic in Rochester, Minnesota, where she holds multiple leadership roles, including interim chair of the Division of Public Health, Infectious Diseases, and Occupational Medicine, medical director of the Physician Health Center, and associate medical director of Occupational Health Services. Her dedication to workplace safety, occupational health, and preventive medicine shines through in her influential clinical work, groundbreaking research, and commitment to mentoring the next generation of physicians. Throughout her inspiring career, Dr. Swift has focused on critical areas such as latent tuberculosis infection, infectious disease exposures, immunizations, and fitness for duty evaluations, always aiming to safeguard both patients and the healthcare workforce. She is an active member of the American College of Occupational and Environmental Medicine and has contributed to numerous national guidelines that shape occupational health practices across the country. So today, Dr. Swift will be sharing insights from her personal and professional journey, offering valuable advice to those of us exploring careers in occupational medicine. So please join me in giving a warm welcome to Dr. Melanie Swift. Thank you.
Thank you so much. It's a pleasure to be here. Thank you for inviting me. And I hope that this will give us plenty of time for questions and answers and give you a little bit of insight into one of the many, many ways that people tend to come into this particular specialty. So I titled this presentation sort of how I became a doctor, because I understand we've got pre-medical students in the audience of this. Stumbled into my specialty, which is almost literally true, and stayed mostly sane, which is perhaps arguable, but I will argue that I am sane at this point. So just a little bit about me. I am from Nashville, Tennessee, Music City, USA. That scene at the top is in the famous Bluebird Cafe, and the guitarist is an old friend of mine, actually. So that was an interesting milieu in which to grow up in the 70s. And then I attended college still in Tennessee at a small liberal arts school called Rhodes College, where I did a bridge major in biology and psychology, another very musical city. One of the impactful things that will sort of come back later in my trajectory is the fact that my mother was dying, in the process of dying throughout my college years. She had metastatic breast cancer, and had a very slow and lingering death throughout my college years. And she died in October of my senior year of college. I probably took 2 or 3 days away from school to go home for the funeral, and then went right back into my studies without really skipping a beat, so to speak. Then I entered medical school at the University of Tennessee, Memphis, where I was not exactly, I did not exactly fit in. That's me up there. I was kind of a hippie. The picture at the bottom is a picture that I took during a summer I spent in Berkeley, kind of finding myself. The picture on the right is currently on the University of Tennessee, Memphis website, showing people that are very clean shaven and wearing ties and wearing white coats. And, I was running around in Birkenstocks. So it was an interesting place for me to be at the time. Medical school for me was tough, actually, after academic success in high school and college. I got to medical school, and I struggled, honestly, in medical school. I felt like I didn't really fit in. I found, a small group of friends that I felt close to. And for the first time in my life, I experienced an academic struggle. In the second semester of my second year of medical school, I was failing a class, pharmacology. And what was going on for me at the time was that I was experiencing sort of delayed grief from the death of my mother and didn't really recognize what was going on until one day I was in a grocery store, tired and stressed from medical school. And I heard very clearly in the next aisle my mother speaking. It was her voice. At least that's how I interpreted it, until I tiptoed around the end of the aisle and looked and saw the face of the woman who was speaking, who looked nothing like my mother and suddenly sounded nothing like my mother. And that's when I realized I need to talk to somebody about this grief that I've been just kind of powering through for too long. Um, Fortunately, I had a professor who recognized that this was aberrant for me, that something was going on. And he called me to my office and he said, "What's going on? Your grades in this course are terrible." And I told him what was going on. And he said, "Look, you can repeat this class. Why don't you drop this class? You're passing everything else. Just put your effort into those, reduce your load a little bit, and let's plan for you to retake pharmacology. It's not the end of the world." It was a very compassionate thing for him to do, and he steered me towards some counseling. So I was also having insomnia and anxiety. And I got some counseling. I took some medication for a short period of time, and then I took a year's leave of absence because I honestly didn't know if I really wanted to be a doctor. I didn't know if I could find my genuine self and still fit into this hierarchical, kind of formal world of the house of medicine. Um, and what happened was that I had a choice of taking the pharmacology classes at a couple different places. I took it at the University of California, Berkeley, where I did feel that I fit in and I thrived there. I did very well in the class. And then I spent a year working, using my psychology training as a counselor at a women's health clinic. And at the end of that year, I could see a pathway where I could keep my own voice, be myself, be true to myself, and still take care of patients the way I wanted to and become a doctor. I was very fortunate in that I had a full scholarship to medical school, and they held that for me during my year's leave of absence and welcomed me back. And in the clinical years, I felt much more like this was the right thing for me to do. So that's how I ended up actually becoming a doctor. I chose internal medicine, and I was going to do primary care. So I went to a program affiliated with Brown University at the time, in Providence, Rhode Island. Did primary care and took my first job out of residency back in my hometown of Nashville at Vanderbilt University Medical Center. And there I did typical clinic, outpatient practice as well as inpatient internal medicine, um, with a couple of months a year attending on the inpatient general medicine ward. Had my own continuity primary care practice and did quite a bit of teaching. By the end of my first 5 years there, I was the associate program director for ambulatory education and director of the residency continuity clinics. And I enjoyed that, but it was a lot. I had My child was young at the time. Um, we did all of our own inpatient care when one of our primary care patients was admitted. We did not have any shared night call weekends. So this was around 2000 to 2001, and this concept of hospital medicine wasn't yet a thing. and even shared call responsibilities were not a thing. And so it was very much about everyone sort of doing it on their own. And fortunately, medicine has evolved to more of a team-based approach, but it was not that way in the year 2000. So I got sort of an opportunity that fell in my lap. The medical director of occupational health um, at the clinic that focused on the Vanderbilt employees was retiring. And the director of health and wellness, who knew me, reached out to me and said, would you consider this? You know, it would be a change for you. Um, but I think that you would be good at this. And we need someone that understands how the medical center works. We need someone who could talk with doctors and have them listen. We need someone who can represent us on committees, talk with administrators. And I said, I don't know anything about occupational medicine. And she said, yeah, there aren't many people trained in this specialty. But there's an organization, there's a society called ACOM, American College of Occupational Environmental Medicine, and they have lots of continuing education. You will get on the job training, and there are some courses that you can take through ACOM, and I'll mentor you. And you can learn what you need to know, but you already know medicine, and that's a lot of it. And I think you would like this. So I looked at that and I thought, well, it is interesting because I would get to see a bit more about the other side of the Vanderbilt campus, not just the medical center, but also the university. They had lots of workers that I didn't normally interact with, you know, groundskeepers and pottery instructors and psychologists, all sorts of different specialty, different professions. Um, but also just from a work-life balance perspective, it meant not doing hospital care, not being on call for weekends and overnight. But I had this trepidation of, I don't know if this is real medicine. You know, what is this going to be? Am I going to get bored? I'll probably get bored, right? And I'll go back to real medicine in a few years. Is this even a real specialty? So I'm going to come back to what happened, but just a kind of an overview. When we think about specialties, this is just my own personal take on it. We kind of think of specialties as monolithic, like you just pick a specialty, but really they have different emphases. There are some specialties like that guide you toward primary care, where you have to be sort of an expert, and you do have to be an expert in many chronic conditions and common conditions. And so that's things like family medicine. Then there are things that are pathophysiology based. So you have to have deep expertise in a specific range of conditions. So you're a cardiologist, you know everything about the heart, but you don't need to worry as much about ankle sprains, right? You don't treat that as a cardiologist. So you sort of limit the care that you provide based upon what the condition is. Then there's procedural specialties, where regardless of the pathophysiology, you have to learn how to do specific procedures really well. So general surgery, interventional radiology, et cetera. There are specialties that are based on the care setting. Is this an emergency department, where the goal is to stop people from dying and then figure out where they go? Basically, that's what you do in emergency medicine, right? There are hospitalists now, and they're adept at, how do you deliver care within a hospital or within a long-term care center? But then there's this group of specialties that are really functional in nature. And the focus in these specialties is helping patients reach a specific functional goal. So physical medicine rehabilitation is one of these. You know, if you go into PM&R, you might be treating people with head injuries or strokes or, leg fractures. It doesn't really matter what the condition is. You're trying to help them walk again, for example. And occupational medicine falls into a functional kind of theme where, regardless of what the condition that the patient might have, you're trying to help them get back to work productively, safely, or they may be in an environment, it sort of crosses over into that special care environment of a workplace where there are hazards. And this is why occupational and environmental medicine are in the same specialty. Environmental hazards that exist in a workplace, like a chemical plant or a nuclear power plant, have potential ramifications for the environment outside of the workplace. Um, and the more we learn about environmental impacts in the workplace, the more we also learn about the general environmental impact on human health, and vice versa. So climate change is an example. As we learn more and more about the impact of heat on human physiology and health, we then need to apply that in the workplace, right? Because we have people who are working in hot conditions. So it's not to say that this is it's kind of an exclusive rubric, and there's lots and lots of overlap. Certainly there are people who, in OBGYN, for example, they may serve as the primary care physician for that patient. And it's also a procedural specialty. So there's overlap in these different things, but in medical school, we tend to focus on things that are primary care or pathophysiology or procedural, and don't really think as much about these other specialties. Although I had actually never been exposed to occupational medicine until I was in practice. So what is an occupational and environmental medicine physician? So this is one of the three types of physicians of specialties that are certified under the American Board of Preventive Medicine. They have public health and general preventive medicine, occupational environmental medicine, and then aerospace medicine. And these have in common looking at populations as much as individual health. So people who go into public health and general prev medicine tend to take jobs that are working in a public health department or a governmental agency, or they may go into research and academia, and they're looking at how can we impact the health of the whole population or a whole group of people. Occupational and environmental medicine focuses more, at least in the occupational piece, on occupational populations. So people who have unique job requirements, demands, or hazards based upon what they're doing, like firefighters or other types of specific professions. I'll show you some examples later. And then aerospace medicine is about the particular occupational and environmental demands of space. So people who go into aerospace medicine tend to take jobs in the space industry, usually with NASA or one of the commercial space flight companies, but they also are experts on aviation in general, and often do evaluations of pilots and flight crew, etc. So it's kind of a narrower focus of occupational environmental medicine, if you will. So OEM physicians are experts on the impact of work on a person's health, and they're experts on the impact of an individual's health on their ability to do work or do their job. And OEM physicians can have jobs where they're focused on individual patients and or a whole population. And often it's an and. So an OEM physician might have an outpatient clinical practice where they see injured workers, for example, and help them get back to productive work. And they may also consult with large employers on ways to prevent injury in their workers or help their workers be healthier in general, or help their company reduce healthcare costs and have better productivity. There's lots and lots of different applications of the specialty for employers. But often people do both, a little bit of clinical and some sort of advisory work as well. This is a specialty where there's a real interface between the care you give to an individual patient in this milieu. There may be regulatory requirements, and also interpreting what we know about science as that evolves and how to apply that back to the workplace and to the individual worker. Above all, you really have to be flexible and creative because you get some really interesting situations that are based upon what the person needs to do for their job. And so you're the one thinking about how do we solve this problem so that this person can end up getting back to what they love to do for a living. So once I agreed to take this job, and as I said, I thought I might get bored. My first day in clinic, I saw a psychology researcher who had been bitten by a monkey in the research lab. The monkey was a macaque. And macaques, if you've seen them, they're large monkeys. They have very large teeth. This person was lucky that they didn't have a worse physical injury. But what I learned is that macaques carry a rare zoonotic disease. It's a type of herpes like we get when we get a cold sore. And that's all it is for the monkey. But if a human contracts this infection, it's got a 70% fatality rate. And so this is a medical emergency, and it requires treating the injured worker and also doing some testing on their wound to see if that's contaminated with this virus, and also calling the veterinarian who takes care of the research animals and having them sedate the animal that caused the bite and collect samples from them. And then you collect all of these samples together and you send it off to the special National Bee Virus Laboratory in Atlanta, Georgia. And you await the result to find out if this monkey was contagious or not. And it was very interesting. This is, I've never heard this before, and I would never have been exposed to this in my primary care practice, right? Also that week, I had a surgeon who had a needle stick from while doing surgery on a patient who was HIV positive. And this was in 2001, prior to the time when viral loads were low. And at that time, a HIV infection was devastating. And so that was, we have to start post-exposure prophylaxis in a really rapid fashion. And then I also saw someone who'd been shot in the eye with a laser that they were working with in their laboratory. It was like, I don't think I'm going to be bored in this specialty. And in fact, I haven't been bored for a minute. I've been now doing occupational medicine for 23 years. I spent 17 years in that position as medical director of occupational health at Vanderbilt, thanks to a lot of mentorship from a senior occupational physician, thanks to a lot of support from ACOM, where I got exposed to a network of other OEM physicians doing this work in medical centers. And over the years, have been able to I've really been fortunate to serve in some leadership roles, to do research and publishing. And then 8 years ago, or 7 years ago, I guess, I was recruited to the Mayo Clinic. And at that point, they said, you've been doing occupational medicine for a long time, but we really require that you be board certified in your specialty. And there's a program that you could do. If you come here, we'll support you to do this. And so I did go and do officially another residency at 50 years old. And the University of Pennsylvania has a program that allowed still does allow you to continue in your practicing occupational medicine and then do this distance residency through the University of Pennsylvania. So I did that and got officially board certified in occupational medicine as well. So the occupational issues that I see are varied and depends upon the population. So like healthcare workers, obviously I saw a lot of those. I recently evaluated a surgeon who had a hand disorder and needed to essentially wear an exoskeleton on her fingers in order to not in order to have good control of her fingers. And so we did an extensive evaluation, including simulated surgery using a cadaver and using some training models to see if she could safely operate these with these splints on her fingers and not have holes develop in the gloves, for example, not lose any control. And so that was a fascinating thing to get to do. We see commercial pilots in our division to determine if they can safely fly or at risk of sudden incapacity. So we might have a pilot who's got multiple cardiac risk factors, and you have to assess specifically, what is their risk of sudden incapacitation? Can they safely fly? A truck driver who's taking pain medication, how sedated are they? Are they able to be certified to drive a commercial vehicle or not? And what's the underlying condition that they're taking that for? And does that impact their ability to do their job? I have a polar explorer that I saw who had an abnormal liver test. And this would not have normally been anything terribly worrisome. Usually repeat it, follow the person for a while after you rule out a few common things. But the issue was he was going to be assigned to work for 6 months in Antarctica with no access to any kind of medical care. Really would have to be an expensive and time-consuming evacuation. So there's a consideration of, you're going to be working in an extreme environment without access to care. So how we evaluate this possible liver problem really changes based upon the occupation. Animal handlers, we have at both Vanderbilt and here at Mayo, very large medical research programs where people are working with primarily mice, but lots of other animals. And 20% of these people may develop allergies to the animals they work with. And then those people may develop occupational asthma if their exposure is not controlled. So we'll see people with things like sneezing, wheezing, itching, when they're working with animals, and we need to protect them. There's fitness for duty concerns. I once had a police officer with a hearing impairment. And this person was assigned to do security in a patrol at a mall setting. And there were gunshots heard in the parking lot. So the police dispatcher sent out on the walkie-talkies an alert saying shots fired at this location, which would normally trigger a response for everyone to take that active shooter response, right, where you shelter in place if you can't evacuate. Because of the hearing disorder, the officer heard fire, didn't hear the shots, but heard fire. So activated the fire alarm, which caused everyone to try to evacuate the building out into the parking lot where the shots had been heard. So obviously, this was a serious safety problem. In Fort, no one was hurt. It was actually not an active shooter situation, thank God. But you can see where there's both the interplay of your personal health on your ability to do your job safely, and then also things you may be exposed to at work that can impact your personal health. And so these are the types of issues that we address in occupational medicine. That's more of a clinical practice, but that's only a piece of it. And every physician sort of has their own unique practice. Here's a list, and I would say it's a partial list of the types of things that people might do in occupational medicine practice or an OEM practice. So the traditional patient care and academic work, teaching, but many people are corporate health officers or corporate medical officers. They may do consulting, government work. Military is like the original occupational medicine practice, military medicine. There's really no more hazardous job than going out there and getting shot at, right? Um, and then there are more preventive programs, generally aimed either at employees of the company, or sometimes um, more broad recommendations from more of a public health perspective. Um, Environmental health evaluations, being an environmental consultant. And then there are very specific things. Occupational drug screening is kind of its own mini specialty within that. And there are some physicians that, make a career out of really understanding that and providing their services to interpret drug screen results so that they're fairly and accurately reported to the employer. So there's just a lot of different options, and many occupational physicians do a mix of these things. So my big takeaways, if I have, some points to leave you with, is even though, you're pre-med, you're all very accomplished, you're not going to be perfect. So get over it. It's okay. You're going to need help. Ask for it. If you can't ask for it, but someone offers it to you, at least accept it. Okay. Also know that you're really never locked in. You may think that, specialty X is perfect for you, and then you get into the training and you actually hate it. And that happens, but that's okay. You will always have options. You can change. One of my good friends and colleagues, who's an occupational medicine physician now and actually stepped into my shoes when I left Vanderbilt, was a vascular surgeon in practice and just did not like it, and discovered occupational medicine, loved it, invested in doing the residency, and changed careers, and is very happy and successful doing occupational medicine. One thing I should say is that when they do burnout surveys of physicians, occupational medicine physicians have very low burnout. So it's a profession because I think maybe it's so varied. Um, and also because people have sort of sought it out and found it later in life. People tend to be very happy in this profession. A couple other things I'd like to leave you with is that, medicine is a profession that is never going to say, you know what, you've worked hard enough, you've given enough, why don't you take a rest? It will never do that. There's always more to do. There's always the sense that, I need to work harder, but you have to set your own boundaries. Think of this as a marathon and not a sprint, and you've got to take care of yourself along the way. So you will need to set boundaries around what you're willing to do. I set a boundary finally of, I don't want to be on call 24/7. And that was, not something that I could continue to do if I'd continued in my old practice. And then finally, maintain and nurture a life for yourself outside medicine. And I see physicians, and I work in our physician health center, I see physicians who are still working because they do love the profession, but they struggle to continue to work 100% at that kind of pace and intensity into their late 70s and 80s. But they continue to work because they really don't know what else they would do with themselves, which is inspiring in a way, but it's also pretty sad, right? You should have some other life outside medicine, to be kind of your sanctuary, because whatever specialty you go into, it can be, you'll be exposed to some painful things, and you need a sanctuary away from that. And ultimately, you're going to retire, and you're not going to be practicing medicine when you retire. So find something else you like to do. And with that, I'd love to take some questions and have some discussion. I do have my email there, and you're welcome to email me with questions.
Thank you so much, Dr. Swift. This was an incredibly informative session that we really enjoyed. I learned so much from it. I really loved how you split up the different fields of understanding how each field has its own little bubble. I think that's really going to stick with me throughout med school as I kind of decide what I want to be when I grow up. So we received a couple of questions in the chat box on YouTube and Zoom, and also a couple of that we prepared for the teleshadowing team. So I'll just be conducting our Q&A session slash discussion. It's very informal. So to begin, we were curious to know, how does your typical day as an occupational medicine physician differ from your life in internal medicine?
Um, there are days when it's similar. Yesterday was a clinic day for me. So, it was not that different in terms of what I was doing. The topics I was discussing were a little different, but I was seeing patients, they were getting, moved to an exam room, and I would go in and talk with them one-on-one. There are many days that I have a learner who's with me, a trainee who goes in and sees the patient first, and then I precept and we discuss, and I teach. And so in that way, it's similar. But on other days, I may be consulting with I'll be working an occupational health role, wearing my occupational health hat, in which we're focused on the safety and health of our workers. And so I might be talking with our infection prevention and control team about a tuberculosis patient in the hospital, and determining which of our workers would have been exposed significantly. There could be any number of issues that arise sort of out of the blue that don't have anything to do with a patient that I'm seeing, but is my responsibility to help sort out. I also supervise a lot of programs, and that's very different. So, for example, I mentioned the animal research facility. We have a program to do medical surveillance for the animal allergy worker and for the animal workers, doing surveillance to detect any allergy that's developing. And so there's a more of a formal process of identifying them and educating them and reaching out on a regular basis to do a survey to see if they're having symptoms. So that's one type of medical surveillance. We have people that are exposed to loud machinery, or helicopter noise, and their hearing is at risk if they aren't properly protected. And so we do annual hearing audiometry tests for them to detect hearing loss. And so I might be presented with the results of abnormal tests on people. But then we also look at patterns for the population. Gee, all of our hearing loss seem to occur in this group of workers. I think we need to go over to that plant and see what's going on and talk with the safety folks. So it's not one-on-one medicine. There's a clinical component, and you have to understand what's going on, but you also have to apply that, evaluate the data that you get from that, and use that to make the workplace safer. So it's this feedback from the individuals and to the population that you don't get in a primary care practice in internal medicine, unless there's some big situation going on in a community and suddenly all your patients are showing up with the same constellation of symptoms. That might be one way in which you would then call public health, and you would at least report it. But in occupational medicine, you get to look at data from across the population and then say, oh, here's a pattern, or here's something that we didn't expect. now let's dive into that and let's talk to the supervisors and let's talk with safety and let's figure out what's going on. Let's go over there to that work site and see what's happening. And because of the programming that we get to do, I get to do some really novel things, like figure out how to get Ebola vaccine for our workers that are in our designated, Ebola treatment center. That would be, we don't have any Ebola patients, thank God. But if there were any, they would come to this particular unit. So these workers need to be vaccinated, which is a whole rigmarole kind of to get the vaccine. And it's not a typical thing that you would do in a primary care practice. So I like the variety of it. Sometimes it's more data-based. Sometimes it is, a unique problem that has come up or a new program that needs to be started. So I like the variety of that with being able to see patients one-on-one as well.
Thank you, Dr. Swift. That really gave me a good idea, and I love how dynamic it is.
Mhm.
And you mentioned a lot about like the importance of mentorship and your involvement with ACOEM. That's a website we're also including in all of our notices sent to our students after the session, also before the session. But how did these relationships and professional networks really shape your career path?
Oh my goodness. So it's a very small specialty. I think there's around 3,000 board certified occupational physicians in the country. And so in any community, you don't stumble across other OcDocs, So what ACOM has done is given me a way to find other physicians. And then within ACOM, there are special interest sections. So, there's a section for people that do transportation medicine. There's a section for people who do corporate medicine. There's a section for people who do medical center occupational health, which was what I was doing. There's also an academic section. There's like 20 something sections. So you can, through that, it's a way to find people who have not only an interest in and are doing occupational or environmental medicine, but are interested in the exact same niche of it that you are. You'd never find these people otherwise. So what that has allowed me to do is one um, to benchmark, to have the phone a friend. Have you dealt with this issue before? How did you deal with it? And so that's priceless, having that phone a friend capacity. I've also been able to collaborate with others to write guidance documents for because we can't be everywhere, and so people who might be like an infectious disease doctor and is asked, by their hospital, what should we do about this particular occupational infection? They need some guidance as well. And they need to understand what are the limits of requiring vaccinations for people who, is part of their job and et cetera. So we provide guidance to other specialties through this organization. And so it's been really important to my career. It was how I networked and met people here at Mayo, so that when they had an opening, they recruited me to come here. So it's a very important part of my professional life is to have this organization. Otherwise, you can kind of feel like you're in isolation.
Thank you, Dr. So that was really helpful. And recently I was reading a couple of articles about occupational medicine as a whole. The physicians in it are retiring or it's sort of aging out. I guess there's also a lack of awareness in medical schools about the specialty. I know this is not a specialty that we're usually educated about. I talked to my friends at other medical schools, they had never heard about it, but Dr. Clorin at my medical school, she actually like had a whole like a session hosted for just like us as a whole. So now we had no excuse to not know that what occupational medicine does and is. But we are still curious. This is not something I learned actually. Like how long, or maybe I've just forgotten. But some students are also asking this. How long is the occupational medicine residency?
Oh, it is a 2-year residency that requires one preliminary year. So you have to have had one clinical year doing, some clinical training before you do occupational environmental medicine. So it's a 2-year training after that incorporates getting a master's of public health.
Got it. And is this the same
Go
as
ahead.
like preventive medicine? And that's like, and then you choose one of the three tracks, like aerospace medicine, preventive medicine, general public health, and then the third is occupational and environmental health.
Right. There are 3 different types of fellowships or sorry, residencies, and they can be, and they're different. So, a given institution might have a training program in public health and general preventive medicine, but not in aerospace or occupational medicine. Or they might have occupational and aerospace, but not preventive, or they might have preventive and occupational, but not aerospace. So they operate really like independent residencies, and the board certification specific to the type of residency that you take. Yeah.
That makes a lot of sense. I did not know that before. I thought you have to do like a fellowship after the preventive medicine residency and then pick aerospace medicine or
I think
something.
the confusion is in that terminology is that the institutions that have residency programs can designate them as internally as a fellowship, which means, well, for our residency program, we're actually only going to accept people who have another previous completed training. It's still, from an ACGME perspective, it's still a residency.
Understood.
So it's in the terminology. In medicine, we call things a fellowship if it require, if you have to have completed another training first and it's your second training. But occupational medicine uh, can be done straight out of medical school if someone wants to do that. And there are training programs that are situated as residencies, and they'll accept people straight out of medical school or after another training program. There are other, and then other programs might say, we are only a fellowship. We're only going to accept people after they've had another training program. So it's really program dependent, but officially they're all residencies.
Got it. Thank you so much, Dr. Swift. And Dr. Clorin also shared in the chat box that we're going to share as well. And we'll try to also make a figure if there isn't already about the training pathway into occupational medicine. And speaking of which, there are a lot of different settings. Like there's a wide variety of settings in occupational medicine, from healthcare workers to polar explorers, like you were talking about. Could you tell us like a specific memorable case or a population that highlighted really the diversity of this field to you?
Oh gosh. Um, there's so many.
You can be
Um,
top three, top five, top 10.
okay, okay, all right. Um, let's see. I had a patient here not that long ago who was referred to me by their pulmonologist. Um, he had an unusual condition called cough syncope, and that's passing out when you cough. And so, what this guy would have is anything that made him cough, whether he, had a cold or inhaled some dust or whatever, when he coughed, he would faint, would just drop. And so it's very distressing. And the problem that he was referred to me for was that he's a power plant operator. And I didn't really know what a power plant operator did at first, so you have to look into, what is this profession? What is it that you do? And it turns out he's in a power plant where he's the sole controller of the power sources and supplies over his shift. He's in the control room, but he also has to walk on these catwalks across this giant plant at a height where if he passed out, he would fall, likely to his death. Also, if he became incapacitated, and he's alone in this control room, this could have devastating consequences for what would happen to that power plant, what could lose containment, what could overload, etc. So it was really this interplay between the condition, can it be well controlled? Can it be mitigated? Has every effort been made to make him, as good as he can get medically? And then given that this is as good as it's going to get, can he return to this job? He ultimately couldn't return to that job, which was sad. However, he did call me. I'd also told him he couldn't drive, because this was very unsafe if he were to cough and pass out behind the wheel. And he was upset. He was very angry about that. Um, so another skill that you have to develop in occupational medicine is helping counsel somebody through very difficult decisions about work. They either want to work and you think they should not have that job, or they don't want to work and you think, yeah, you really should be able to do this. So having that negotiation or that education, that sort of compassionate uh, discussion with the patient is a skill, that's another sort of diverse aspect of occupational medicine. Sometimes you have to tell a pilot they can't fly, or a truck driver they can't be certified to drive, and they don't like to hear that, but it's for public safety, and you've got to explain to them why. So I explained this to him. He was very unhappy with me, kind of stormed out of my office. Um, and then about 3 weeks later, I had a call. The nurses said he wants to call. He wants to talk to you. He won't tell us what's going on, but he just wants to talk to you. And I thought, uh-oh, this is not going to be good. And when I talked with him, he said, I just want to thank you. I fussed and fumed. I did not want to give up driving, but I kept hearing your voice, and I said, okay, so I didn't. And he said, a few days after our visit, I broke down and had my wife drive me somewhere that I otherwise would have driven myself. And while we we're on the highway, I coughed and I passed out. And I realized I could have killed somebody or myself. And so I want to thank you. So that case kind of stands out for me. Kind of at the another end of the spectrum, we had a researcher who started to work with diphtheria toxin. Diphtheria has been largely eradicated, especially in the United States. But diphtheria toxin is highly lethal. And there is an antidote, but it is in limited supply worldwide because diphtheria is not that common. And what this researcher was going to do was inject mice with diphtheria toxin. Mice don't have receptors for it. And so they were using extremely high doses of diphtheria toxin in this particular research study. And so the amount of diphtheria toxin they were handling at a very small 1 ml injection could have killed over 100 people. It was that lethal. So to protect our workers, we had to ensure that they had immunity to diphtheria. Now, this is not something that you typically deal with, in the United States in medicine, right? And what's the amount of protection that they need? Kind of, is there a way to measure their immunity to diphtheria? How do we get antitoxin to them if they did experience an exposure and needed it? And it turns out to be this very interesting intellectual exercise, and also talking with people at the FDA, talking with people at the CDC who have the stockpile for diphtheria toxin, determining how we would get it, working with our emergency department to have a protocol for administration of it. If it should happen, we would have to get the antitoxin delivered, by plane from Atlanta to our site, and then ferried from the airport to the emergency department. And then there's a whole protocol for checking for allergy because it's from a horse serum. It was just like, it was crazy. So many steps in going through it. But ultimately, we put a program in place. And it's become an increasing hazard that people work with in biomedical research. It's very useful in building certain animal models of disease. And so now we have a program and other institutions use that program, that process of making sure that you're establishing immunity in your workers and having a plan for an unexpected exposure. So kind of that's the kind of the diversity. Um, you deal with the personal issues, you deal with population issues, anticipatory things, as well as reactive things, and then interpreting regulatory, incorporating regulatory guidance, because of course um, there's a lot of regulation around giving a medication it's only an investigational agent now. This diphtheria antitoxin. So lots of different things that you get to learn along the way.
That's amazing. And you speaking of learning new things, another student was curious about how you stay updated, like on the best practices, new laws, and things like that of that nature.
Right. There's sort of two different streams. One is maintaining awareness of what's happening in the field scientifically. So subscribing to journals helps with that. Increasingly, we rely upon um, knowledge synthesis of what's published and being able to access the tools that you need to answer specific questions. And so one of the tools that I use most now is open evidence. So that's an AI based medical um, tool that helps to answer questions. You do have to have a national provider ID in order to access open evidence. So as a pre-med student, you wouldn't have access to it yet. You have to have a license and then a national provider ID. So um, but that is something that it's a little bit like Chat GPT, but it is really curated and designed for medicine. And it has to it provides citations. So it's a way of kind of doing a literature search, but also synthesizing the data to answer questions in an evidence-based way. So, I use that recently. I review biomedical research protocols that work with a hazard, and had one that they were going to inactivate these primate cells with a certain solution. And so I queried, will this inactivate herpes B virus? Remember that first case I had of the monkey
Mhm.
bite? That sort of continues to be a theme when you do biomedical facilities. And immediately got like 3 citations of, how does this particular chemical work on deactivating this family of viruses. It was very helpful. So you have to keep up to date. I do subscribe to the Journal of of ACOM, the Journal of Occupational Environmental Medicine. I get journal alerts that come through my email. The regulatory requirements is a little harder, and that largely consists of signing up for different email subscriptions. So Department of Transportation, OSHA, the CDC has a long list of topics that you can sign up for alerts. So I get things like immunization, changes in recommended immunizations, changes in news that has to do with environmental health, news that has to do with any occupational topics. So you can sign up for these things to kind of learn about changes that are happening. But and then the network, having um, the group of specialists that I have through ACOM, where we have email distribution lists, and we can say, hey, has anybody heard about this? And you get answers from your peers. So lots of different ways.
Thank you, Dr. Swift. And Dr. Clorin also talked similar about what you just said. She just mentioned the chat box. Like the community is great on social media, and you also network with each other and share information that way as well. So I like how she mentioned it's a generous community of practice. So I love that a lot.
Yeah.
That's amazing. Another one of the appealing parts that you mentioned about becoming a medical director was no weekends or overnight calls. So could you tell me a little bit more about how occupational medicine supports a better work-life balance compared to the other specialties?
Yeah. It's a team practice. So it's not an individual practice. For at least it hasn't been for me. Um, and because most of what we do that is really time sensitive and clinically urgent, dealing with a work injury, um, to stabilize the patient and get them their initial care, that is general urgent care. That is general emergency department or urgent care center kind of work. So after hours, it's not necessary usually to address, gee, is there a pattern of this type of injury at this plant? It's just stabilize the patient, take care of the patient for what they need. And then if the employer has questions about, you know, how do we prevent this from happening in the future? Or, this is our third injury like this. You can answer that question the next business day. It's not the time sensitive part. So the part that we have to, it really does come to an occupational medicine physician level of decision making usually isn't the time sensitive part of it. That said, I do get calls sometimes on the weekend, um, the director of our laboratories has my cell number and can call me if, hey, we had this very weird select agent in the lab over the weekend. And so that does occasionally happen. But it's not like you're listed as always being on call. And you have to have systems in place, so if there's a needle stick that happens after hours, we do have a 24/7 service, and it's manned by an occupational health nurse. And then we have after hours sort of collaboration between infectious diseases and OCMED. So there's somebody on call anyway for infectious diseases that can provide any clinical backup that's needed after hours. Every institution does that a little bit differently. At Vanderbilt, actually, our emergency department provided that. But wherever you are, and whatever you're doing, there's generally some partnership that you can develop to who are people who are already working during those hours, to do what they need to do, just what needs to be done at that time, and then you can handle the rest of it during a business day.
Thank you so much, Dr. Swift. And we're getting to our last two questions now. We really appreciate it. So looking ahead, what do you see as the biggest opportunity or challenges for occupational medicine in the next decade, especially in the light of new technologies and also the evolving workplace safety standards?
Right. I think that our biggest challenge right now is ensuring that we have a pipeline of trainees entering the specialty that will be enough to continue the specialty as people retire. You mentioned the aging of the specialty, which is true across medicine, but I think even more so in occupational medicine. About half of our um, members and physician members in ACOM are actually over 60 years old, um, 60 or older. So that's a big issue. I think it's 45% that are age 60 and older. And we have a small number of training programs. Occupational medicine, most specialties are actually funded um, through the Medicare and Medicaid system that has funding set aside, and they pay hospitals to train all different specialties. The exceptions to that are the preventive medicine specialties, or at least occupational medicine. I'm not sure about general prep med, but occupational medicine and aerospace medicine do not receive that funding, and pediatrics. But pediatrics does have other federal funding. Occupational medicine training programs have been funded by largely through NIOSH grant, the National Institute for Occupational Safety and Health, and then through through other grant funding. It's not part of that Medicare, Medicaid, because our work isn't so much focused on hospital care or kind of the traditional training setting that the others are. So ensuring funding for continued training programs is a big priority, and ensuring that we have enough training programs to train the next generation. So I think that's our biggest challenge in the near term. Meanwhile, I think we need to amplify the voice of occupational medicine physicians, because some of what we do on the front lines can be done by others, with occupational medicine physicians providing that expertise for things about, things that deal with the interface between the clinical situation and the workplace. And so we, more of a consultant and role, and maybe advocate or representative of an employer, rather than so much, we can't take all the occupational trained physicians and just send them out to urgent care walk-in clinics around the country, right? That would dilute that expertise and not make it available to other people who could be doing urgent care.
Right. Thank you, Dr. Swift. And that makes you cautiously optimistic. And now it's horrible that it's really like CMS and Medicare that, they're key to receiving that funding. And that might be why the downstream effects have been less medical students being told about the specialty to begin with. A lack of awareness is, I would say, the key thing. So I'm really glad that we're using this platform to, have
One other
occupational.
thing, I'm sorry, but it
Go
just
ahead.
occurred to me, this year is the first year that occupational medicine will be in the residency match. So the
Oh,
National Residency Match Program includes all the traditional specialties, but there are some specialties that are smaller, that don't participate in the match. So this year, occupational medicine is in the match. And what that means is that even if people don't pick it, they at least see it on the list, right? If you never get exposed to even what is this, you're not going to have that curiosity to find out more about it. So I do think that will help with visibility for at least filling the residency training slots that we have. But ultimately, we need more slots.
I had no idea that it wasn't already on the on the
Yeah.
match website, so that's good to know. And I mean, I'm a second year, so I wouldn't have known anyway because until fourth year. But thank you so much for sharing. And our last question is: you talked about advice, and you gave us amazing pearls of advice to pre-meds. What about for medical students or residents who are interested in exploring occupational and environmental medicine, but they're unsure how to get started?
Mhm. I think that they can, first of all, try to find an occupational physician in your area, and you can go to the ACOM website to put in. There's a physician finder there, so you can put in your location, and it'll show you the at least the ACOM member OCMED physicians that are in your area, and so you can reach out to them. There's also the AHEC, AOEC. I'm sorry, forget the abbreviation. It was on my last slide though, which is an Association of Occupational Health Clinics. And that has, the physicians there may or may not be ACOM members, but they're occupational physicians. And so that's another place where you can find a potential mentor in your area to learn more about the specialty. And then, of course, ACOM has a lot on their website. And there's a resident membership that is, it's not no cost, but it's very inexpensive. So even if you're not an occupational medicine physician resident, but you're a resident or a medical student, you can actually join ACOM and learn more about it that way. And if you're a medical student or a resident, you can join special interest sections in ACOM. So if you're interested particularly in public safety medicine, police and firefighters, and that type of thing, there's a section, and you could join it, and you would be part of that network, and you'd be learning from other physicians in that area. So those are some suggestions to get started. And Dr. Cloran probably has others too.
He'll probably give us 100 more ways.
Yeah.
No, but I love it. Dr. Clorin is amazing at our school and truly a powerhouse. Well, thank you so much, Dr. Swift. Those are all the questions that we had for you for today. We love everyone to please give a warm thank you in the chat box to Dr. Swift and for this inspiring and informative session. Thank you so, so much.
Thank you so much for having me.
Thank you. And now we're going to conduct our closing session with our quiz and future session dates. So the link to the quiz for this session with Dr. Swift is now live. As always, you will need a 70% or higher to pass and receive certification. And I'm sending the link to the quiz in the chat box now for our students. And now on to our future session dates. These sessions will also be posted throughout our social media outlets, so please be sure to follow us at TeleShadowing. And our next live session will be tomorrow, January 11th at 11 a.m. EST, actually 10 a.m. EST. Thank you, Slide, for correcting me. With this session will actually be with Dr. David Cockrum. So I'm excited for that. And all of our other dates for Occupational Medicine Month are also posted on social media websites. And thanks so much, everyone, for attending today's live session. And we hope to see you in upcoming sessions as well. And this concludes this week's shadowing. Thank you so much, everyone. Take care. Bye.